Hi, my name is Mike Wright. Today is our second expert interview. I am here with Megan Martin from Perfect Finish, who is the Vice President of a laboratory in New Jersey. Today, I'm super excited for this expert interview. We're going to be talking about TADs, expanders, all things metal. It's something that is hitting the market everywhere. We see it here at our laboratory. I know that Megan and her folks at Perfect Finish see it, and they really are the experts at these. So I want to welcome you, Megan. Thank you for joining us today.
Hi, thanks, Mike.
We're just going to go through our normal format. I'm going to ask you a bunch of questions. We're going to talk about the TAD appliances. What are they? What do they do? How do they work? How do they relate to the laboratory, doctors? So we'll just kind of dive into all of it. But I do want to start with just an introduction. Megan had an article in the LMT, and she was featured in there. She's not embarrassed about that at all. But they had some really great things to say about you because you've been doing this for a long time. So I'm certainly honored here to talk to you. You've been in this industry, and you just know the nuts and bolts of all of it. So in 2001, you were just 18 years old, began working at Perfect Finish, who's owned by Phil Pellegra in Hackettstown, New Jersey, as a trainee in the finishing department. And then you immediately liked the work and over the years mastered every department in the lab, worked her way up to management positions and took on other special projects. She and coworkers spent months researching 3D printers, ultimately launching a new digital department to automate model production. Today, the department has 9 printers and 3 staff members and receives 40% of its impressions digitally. In 2019, Megan was named Vice President General Manager, but still helps out at the bench, working on the fixed expanders and helping to finish cases. So you have been doing this for a long time. Good for you.
Yeah, 20 years.
I think it's a pretty typical journey where you start at a younger age and then just work yourself up, but learning how to do every single thing. You want to talk about that just for a second? Because I always find that fascinating because that's similar to my story.
Yeah, it was just, I answered an ad in a paper, needed a job, and I came here not just kind of expecting a fill-in job until I figured out what I wanted to do, if I was going back to school. And I ended up really liking it. I thought it was fascinating. I didn't realize people actually made appliances. I always thought there was machinery that did it. So yeah, it was really cool. And then the more I started doing, I wanted more challenges. So I wanted to help design cases. And, when we were talking about the 3D stuff, like that was interesting. That was a whole new avenue to explore. So I like the challenges of it too. Not just sitting there, working all day, having to, think and learn new things. It's always exciting.
So your favorite, what would be your favorite part of the laboratory? Is it the digital and new creation of new things, or do you have a favorite department that you love working in?
Well, I'm kind of out of the digital department right now. I kind of started it up, and then as I became the general manager, I had to pull away. I had too much on my plate, so I kind of passed that responsibility off. So I'm really not involved with the digital too much anymore. I do like just sitting and fabricating the appliances probably the most. I do the quality control check before everything goes out after it's all finished, but I do like just sitting and working. I like that, especially when it's a challenge, like the TAD appliances. Sometimes we get some pretty crazy requests, and it's always neat trying to figure out how am I going to make this work and give them what they want, and make it a functional appliance. So that's cool. Probably my favorite part.
Can I ask you one question? Like for any new techs, like what one piece of advice or what pearl would you give them for somebody just getting started?
There's a lot more than what's on the surface. When you first start here, you're kind of just seeing one little tiny part. So, a lot of times people come in here thinking that like that's it, and then not realizing there's so many layers to everything in the lab. Even down to like the office work and scheduling. Having to speak with doctors on the phone and do case design and things like that.
Okay, so what I want to jump into is we'll talk about TADs. It looks like we have some general questions I'll jump into, and then more specifically to what is out there as well. So let's start by talking about just what is a TAD, what is it used for? I know there's specific applications that we use it for, but maybe talk about just a brief overview of what it is.
Okay, so the TADs are temporary anchorage devices. They're used more in adult or teenage patients that have second molars to get better anchorage and help split the palatal suture when you're speaking in terms of RPEs. It just adds an extra level of stabilization when you're trying to achieve something, whether it's, sometimes we've used appliances with TADs where they're trying to extrude a tooth. So they run elastics from the tooth to the TAD, a hook that's attached to the TAD. So it just adds an extra level of stabilization as well. So it's really anchored in there.
So in regards to what we're doing in the laboratory, we are combining that additional anchorage to RPEs. And what would be the benefit of an older patient using one of these? Why would somebody want to use a TAD appliance as an older patient?
Well, when the palatal suture in a younger patient is easily split with an RPE, you get someone that's older that's had the suture, seal up. It's a lot harder, and you pretty much just get the tipping of the molars when you're trying to make space on an older patient. So this has been shown with X-ray imaging to actually re-split that palatal suture in adult patients, where a typical RPE would not do that.
Right. So if an adult is looking for some alternative, I guess the big thing is it's preventing some kind of surgery as well.
Right.
Is that something that you're saying?
Yeah. Yep. Definitely.
Okay. So as far as TADs, like what is the most popular TAD that you guys are fabricating in the lab?
So the most popular one for us right now is the MSE, the Wan Moon expander. We do probably 4 a week, which, it seems like it's not a whole lot, but, a year ago we were doing maybe 1 a week. So it is starting to, we're rapidly getting more requests for these types of appliances, just in the past year. So that would be our most common one because it's, even fabricating it, I feel like it's the most straightforward. It's all a package deal. You can pretty much provide the doctor with the expander, the TADs, the driver to insert the TADs. It's all kind of right there in one kit. It's not a bunch of, piecing everything together.
Is it the most cost effective? Is it one of the more expensive TADs that are on the market or TAD expanders on the market?
Yeah, so it is probably the most expensive. Just, the screw itself is expensive with the eyelets, attached to the RPE already. That would be one of the more expensive options. Just, for the whole kit, it can be, a few $100s for something like that.
Okay, so something to consider as we're looking at these different TADs here.
Mm-hmm.
So I have a question here, the difference in TAD first, TAD last approach, and then the benefits of both.
So the TAD first approach is probably the best for the doctor because it would allow them to place the TADs exactly where they want them in the patient. Whereas the TAD last, they're kind of leaving it more up in the laboratory's hands. And, there can be the communication between the laboratory and the doctor about where we're placing the TADs. So that can be a little tricky sometimes. We figured it out, through communication, it works. But if the TADs are placed first, it's always just easier. But there's limited appliances that allow for that.
Okay, so for example, the MSE or the first expander we were talking about, that is a TAD last approach, correct?
Right. Yep, that's correct.
Okay, and then give us an example, if you can, of a TAD first appliance. What are the offerings along those?
Okay, so the most common one would be an acrylic-borne TAD appliance or a MARPE. you can seat the TADs first, and then it's pretty much just a typical removable expander screw that's placed in the center of, usually 4 TADs. And that's the most cost effective as well, because it's only acrylic and a removable screw. You're not getting the, an RPE screw. So that would be it, but that can get a little tricky because that has to be bonded into the patient's mouth with a light cure, the acrylic's bonded. So there can be some issues with that, and with the debonding process at the end. That's kind of the downfall that we've heard about that one, is sometimes it's hard to remove with the acrylic.
Okay. Okay. And so if we're doing TAD first with the TAD first approach, like the acrylic borne appliances, where are they placing the TADs? Specific places, I'm assuming. Is it based on bone density or
yeah, usually you want to make sure that you are able to penetrate the palatal cortical bone. So that can be determined through CBCT scans. And it's easier for the doctor to be able to determine that location than us. We can absolutely take a look at them and try with the TAD last approach. But again, if it's in the doctor's hands all the way through, they can do that themselves first. So you do want to make sure it's in that area where it's deeply penetrating through both layers, just to get a good solid fit in there.
Sure. Is it common for doctors to send a CBT scan so that you guys can evaluate that? Or are they just telling you where to place it?
We get a mix of both. There's some doctors that always send the scan, and then there's other doctors that will just, either if they're sending a plaster model, they'll mark on the model, like this is where we want it. Or sometimes they even just in the written instructions will say, 5 millimeters below the gum line, between the 4 and 5 or the D and E, that's where we want it. So then we can kind of just measure, like, all right, it looks like it's about right here. And it's usually worked pretty well. We haven't really had an issue with that, as long as there's communication with it.
Okay. Yeah, I guess the big thing would be, how do doctors communicate exactly where they want these TADs? How do you guys communicate? Is it just over phone calls, or if I'm a doctor, what would be the best way to communicate with you? And if I'm a lab on the other side making it, what's a good way to communicate back? What is your experience?
Right now, a phone call is probably best, just so there's no miscommunication, or an email, because then we can always go back and double check, like, nope, this is what he said, this is where he wants it. Yeah, or both, hey, I'm going to send you, the specs that I'm looking for. Give me a call, we can discuss it, that type of a thing usually works best, so that we can both be on the same page.
Okay. And so when we're looking at the different types of TAD appliances, is it preference on the doctor? Is one more effective than another? Because we have 3 different we'll talk about today. We have the MSE, we have the Thomas, and then the acrylic borne Marpy as well. How would you consult one versus another?
That's a good question. I don't know, because I haven't gotten really negative feedback from any of them. The only one I can say any negative feedback was the acrylic borne, because of the removal process. But other than that, as far as functionality, I feel like they're all pretty equal. I don't feel like there's been one more so than another that is more effective, or that a doctor would rather go with.
Okay, so it's just more of a preference for most.
Right,
I didn't know if it had to do with a different diagnosis, depending on the patient.
Yeah, not as far as I'm aware, no.
Okay.
Because there's doctors that just want the MSE, there's doctors that just want the Tomas. So I think it's just more of a doctor preference, not patient.
Let's talk about the 3 different types of TAD appliances. The first one is the MSE. Can you tell us what MSE even stands for?
Sure, it's maxillary skeletal expander. Okay, so here I have a picture of the MSE expander.
Okay. So so we have the 2 TADs in the front and then 2 TADs in the back. So that's pretty much set in stone then.
Right. Yeah. So there's really not much room, to play around with where you're placing the TADs. They all have to go in the same, dimensions.
Okay. And so does a doctor have the freedom to use any TAD that they're comfortable with, or are there specific TADs that have to go with a specific appliance?
Well, there is a TAD that they provide that the biomaterials does provide that comes with the MSE expander. It comes in 11 and 13 millimeter lengths. And that is what is recommended. I believe there are some other TADs that will function with it, but we just had a call from a doctor today that the TADs she had were not compatible. So I'm not sure, it might not work, it might work. There are some that do. But again, it's just as easy for us to be able to provide the TADs that go with it, and that would work. That's always recommended. We would recommend doing that.
I think that would probably be the easiest too for a doc, just to have the kit come as
everything
one.
comes together.
Yeah. So what size do the expanders come in different sizes? Are there protocols for one size versus another?
Yeah, there's 8, 10, and 12 millimeter expander sizes. It's very rare that I've been able to use a 12 millimeter. I might have used one, just because, typically the pallets are very narrow. So, unlike other, the typical RPE, you want to get this as close to the pallet as you can. Even sometimes removing some of the palatal tissue to get it to seat flat against the pallet, it was kind of strange for me when I first started fabricating them, because I'm used to the RPE, like you want to leave it a little bit away so it doesn't impinge. And this kind of has like the opposite mentality, that you want it right up against the pallet. So a 12 millimeter is usually pretty large, and I haven't been able to fit too many into a narrow pallet that needs the expansion, but it is available.
Yeah, it's interesting because it seems like the way that during fabrication, it has to be almost sitting on the pallet, but right where you have to actually sit it is the most constricted part of the pallet, and you're not actually able to get the right size screw down, or the right size expander down that you'd need.
Right. Yeah.
So it's just a mechanical issue I've seen with them as well. So then you might have to go down to the 8 millimeter if needed.
Yeah, that's probably the most popular one that we've, we can use that on most pallets.
And then what's the recommendation where you guys are placing the screw itself?
So typically, if there's no instructions provided, I'll typically try to have the distal, where the distal part of the expander TADs would be placed, right on the mesial to halfway through the sixes or the first molars. That's kind of what I go by. So it's usually not always up deep in the palatal vault like we would try to with a regular expander, but sometimes it's back a little further, like we were saying, so you can penetrate that deeper layer.
Right. It seems one of the things that I heard is there's 3 different factors here. It's super important to place the screws in a certain place so that they don't tip, because if they're not placed properly, or if they're placed too high, or the screw's too high, you could have screw issues, or you could have actually housing issues, where the housing may not properly expand, or the third factor is you actually get expansion. So something's going to give. It's either going to be the screw, it's either going to be the TADs, or it's going to be the pallet itself. And we're hoping that it's going to be the pallet.
Yeah.
So it's got to, I'm assuming it's critical to have these as close to the pallet as possible and get as much penetration into the cortical bone as you can.
Right. Yeah. Yeah, definitely.
Okay, cool. So what are the difference in fabricating these versus traditional RPs? Are they harder to make than a regular RP? Are they easier to make?
I feel like it is a little more challenging, definitely, because there's different parameters that you're working with. Like I was saying, you want to get it close up into the pallet. If you're using the struts, you want to leave them further away. So screw closer, struts further away, because you don't want the struts impinging. So we typically leave them about 5 millimeters off of the pallet or off of the tissue. I don't know what else. I'd say just the need for being more precise with this. You want to make sure your midline's lined up, so you get the straight cut as straight as possible. Same as a regular RPE. I don't know, but I guess that's about it. You also can, with these, it's recommended, in addition to taking away some of the palate to get it closer, you can taper the underside of the screw, the little pegs coming out of the screw, but you don't want to take the length away. You can just sort of taper them to get a closer seat if needed. All right, so here's what I was talking about with the guide pins. You can see in the picture on the right how it's sort of tapered on the underside just slightly, just sort of an angulation just to get it down closer into the palate. Because sometimes that's all that's holding it up from getting where the guide pins need to go, like right up against and flush.
Right, that's brilliant, actually.
Yeah, and then so here's a picture of where we took away some of the palatal tissue to help seat it closer as well. With the transfer tray for the MSE is another option to insert the appliance without using bands. Because the bands really aren't necessary. They're not used for anchorage. You're using the T.A.Ds for the anchorage for the appliance. So typically the bands are used primarily just to help seat the MSE in the proper location. So another option, if you want to avoid using any bands and just go with the screw itself, we could do a transfer tray with the MSE where you would receive it back like this. And then just you want to insert the T.A.Ds sort of like you do with lug nuts, like you want to go top left, bottom right, in a diagonal. You don't want to do the two top because it might, there might be some torquing of the appliance because you don't have, in this case, you don't have the bands really to stabilize it and it could move a little bit. But this is another option I just wanted to throw out there as well. Not as popular. Typically we do use the bands when we fabricate them.
Yeah, and I wonder if it's just an understanding of how these work, because I've heard the same thing where the bands aren't really doing, they aren't pushing anything out. All they're doing is used for stabilization of the appliance, just for the T.A.D placement.
Right.
And all the heavy lifting is really done at the palatal side with the screws or with the T.A.Ds and the screw itself.
Yep.
Cool. So we got a couple different appliances. Next one is the Thomas appliance. If you have any photos of that, it'd be great to see.
Okay, so
this is a system.
Picture. So this is another system. It's also a T.A.D last approach. But with this one, it gives you the flexibility of placing the T.A.Ds exactly where you want them. Now, it does only allow for 2. It is possible to maybe add more, but it's not really standard with these. It would be the 2 on the mesial side of the screw, like you see in the photo here. But again, you can we can move, make it as far away from the expander as you want it, or up, if you want it up closer to the gingiva, you can move it up. Like it doesn't have to be in one certain spot.
So is there a certain benefit using the Thomas system than any of the other systems?
Just with the placement of the screws, probably. That's all I would really say the benefit of this over the other T.A.D systems is the flexibility to move it, or for the doctor even to make adjustments once they receive it back from the lab. They can sort of torque it a little bit themselves if needed to allow for a good path of insertion. Okay.
And you can use any screw that you want when you're using this system, correct?
Right. Yeah. Yeah. Normally the Dentorum screw, it's a Dentorum product, so it's made. They recommend using the Palex system because it's known to not back up. So something like this where you're putting a lot of pressure on, you might want something with that little extra like security, not backing up. But yes, any screw can be used. It doesn't just have to be that screw.
Okay, so we see the difference between the Thomas system and the MSC. It looks like there's some more flexibility with the Dentorum system because you can place the
Mhm.
TADs anywhere you want and then weld that to the screw. The last TAD appliance that we can talk about, which we sort of touched on before, is the acrylic born Marpy. So if you
Right.
have any photos of that, we can,
Yep.
oh, there it is.
Yep. So I
So
have
it
two.
looks like we had two different styles here.
Yeah. So the style on the right would be with the acrylic covering the TADs. And on the left, where we sort of scallop out so that the bonding and leave a little trench on the underside of the acrylic, so that when the doctor places the bonding material over the TADs, it can flow into that trench on the underside of the acrylic to help secure it in place. So on the left, we started doing that design to help with, like I had said earlier, the feedback we got was that it's difficult to remove. So this allows, the doctor to just have to get to the bonding material, not cut through acrylic to get to it. And we do quite a bit of these as well too, because it is the most cost effective, out of all the TAD options.
So what are the differences between, or the main differences between this one and the other TAD expanders?
Okay, so the main difference in this one is that this would be the TAD first approach. So doctors can place the TADs wherever they want it. They're not limited. They can put them wherever they want, and we fabricate the appliance around the location of the TADs. So that would be probably the biggest difference, that and the price.
Okay, so let me, and I just want to finish up on this, this last topic here is doctors are making this choice to be able to prevent a surgical procedure. Sometimes this works and sometimes it doesn't though. Have you seen cases where it doesn't work, or do you have any data on success rate with TAD appliances in adults?
I don't. We have had a doctor, there's one patient that stands out in my mind that it did not work, but that was the only feedback I got out of we've probably done 50 to 100, and out of one out of all of those, they said they didn't really see much. It didn't open the palate, which I'm not sure with all that pressure. It typically does work.
Okay, did you see, were there any issues with that? Did you see any embedding of the wires? Because as it starts to expand more, something, if that's not giving, if you're not going to get your expansion, right, something's going to give,
so
or it just keeps embedding.
Yeah, it was embedding. And yeah, there was tipping in the molars. Like it just wasn't going anywhere. And I think the patient ended up having to have a surgical procedure instead.
Okay.
But that was one case. So as far as data, I don't have anything. I could probably find something.
Okay. Well, I know that there's quite a few studies going on with TADs right now. It is certain, if there's an option to be able to do something non-surgical, I think that's pretty amazing. Especially being able to change somebody's skeletal structure, especially if you are an adult and don't have to get surgery. So I think that we're just beginning with a lot of the studying on this, and I don't see this procedure going away, especially if there's a high likelihood that the doctors are going to get expansion over surgery. So I don't have any more questions here. This has been awesome. There's so much that you guys are doing, some super cool stuff. And how do we get a hold of you if you have any more questions, or if somebody had any looking to get into this on the lab side, or doctors interested to be able to send you guys some work regarding TADs? How do we get a hold of you?
Sure. So they can call here at the lab. It's 908-852-3035. I'm extension 12. Or they can send an email. My direct email address would be Megan, MEGAN, perfectfinish@gmail.com. And I'd be happy to answer any questions, or, if it's another lab person that's looking to get into this that's not currently fabricating these, I would be more than happy to help walk them through, the first few, because they are a little intimidating. And that's what I find a lot of, the doctors even are a little nervous to get started the first time. There's lots of questions and lots of back and forth, and that's more than okay. I'm willing to talk you through it.
Great. Well, Megan, thank you for the interview here. Thank you for your knowledge. You certainly are have a lot of wisdom in this industry. And I want to thank all those who are watching and those who everyone in the ORG. So again, Megan, thank you very much, and we'll talk to you soon.
Okay, great. Thanks, Mike.